So as we continue now with our discussion of step 4 of application of the evidence-based process, we're going to look at a few specific examples on how we can go about using specific different types of information that we have gained through the evidence-based medicine process. And so the first one we're going to look at here is how do we use diagnostic evidence? And so really, when we're looking at how we use diagnostic evidence, we're really focusing now on how do we go about diagnosing an injury. And so that's really what we're going to be focusing on. From there, then, we have to understand how confident are we in the results of our assessment that the athlete or patient does in fact have the condition that we diagnose them with. And so these are the two fundamental questions that we need to analyze and use the research that we have gained in order to help assist in answering these questions. And so the first part where we talk about how do we go about diagnosing different conditions is through pattern recognition. And this is basically the idea that you've seen this before. And so you've seen it, and thereby you understand that this is similar to a different condition in which you know the outcome. And so that's fairly typical. But we can use now a different approach to increase our overall confidence, or in fact to really quantify our overall process to allow for now more confidence in our assessment. And so we do this through what we're going to term probabilistic diagnostic reasoning. And with this, what we're doing is we're actually going to go through and use the diagnosis process in a way that allows us to quantify it or assign numbers to the different possible diagnoses, and thereby allow us to differentially diagnose from different conditions based off of what we know is the presentation of an injury, but more importantly, what also now is the normal test results for a specific injury. So what we're going to do is we're going to look at the different possible diagnoses, and then we're going to create a situation where we can actually rank order and create confidence intervals with how confident we are with these different diagnoses that might be present. So in order to do that, we're going to rely heavily on clinical tests. And so we've talked a little bit previously about sensitivity, specificity, things like that, but we're going to do a much deeper dive now, where previously we talked about it more in how we can go about assessing the quality of the evidence that calculated these measures. Now we're really going to look at how can we use these measures then to allow for us to make clinical decisions. And so in order to make clinical decisions, we need to use quality evidence. Well, at the same point, in order to make diagnostic decisions, we need to assess the quality of the testing procedures that we are using. And so what we want to do is be able to use clinical tests that will be able to predict whether or not a patient has a specific condition or not. And so the idea often is with these that it's very difficult for clinical tests to both be able to accurately predict everybody that has a condition as well as rule out everybody that does not have a condition. And so we need to look at these both. And sometimes you may end up having to use multiple clinical tests to formulate your diagnosis, but by looking at each of these, the ability to rule in and rule out different conditions, we can create a situation where we can use this probabilistic diagnostic approach to create a quantifiable confidence interval for our overall measure. And so when we look at diagnostic tests, oftentimes what we'll see is this 2x2 contingency table where we're comparing all of the different conditions that can be associated with the diagnostic research. Basically, the idea that the reference standard, right, can then be used, and the reference standard is going to be the standard that we're most able to predict what is occurring. So like if it's a fracture, it might be a radiograph or x-ray. Oftentimes it might be some sort of imaging like an MRI, or just being able to actually view the structure during an arthroscopic procedure. But basically, we have the possibility that the reference standard, or whatever the reference test is, in this case, we're looking at x-rays. The x-rays could say that it's positive, indicating that those individuals have the condition, or negative, indicating that they do not have the condition. And so since this is the reference standard, we're going to assume that the reference standard is correct, because that's the best measure of the prevalence of this condition. We then have the possibility that our diagnostic test result could be positive or negative. And so this is where the 2x2 contingency table comes into play. There's the possibility for two boxes which indicate agreement, positive and positive, and negative, and two that indicate a disagreement, in which case we can see that we're going to call the disagreements false, and then based off of their characteristic from what they found by the diagnostic test result that we're testing. So we can have false negatives and false positives, meaning that the test was incorrect, or true positives and true negatives, indicating that the test was correct. And so we get into this situation now where we can create this aspect. In this case, we're looking at this fictitious tibiofemoral stress test and comparing it to arthroscopic conditions. And so if the arthroscopic condition said that it was positive, that would be there. And so we have the 40 individuals now that were tested. And what we found now is the tibiofemoral stress test found that diagnosed 10 of these individuals with a positive characteristic and 30 without. Whereas the arthroscopic condition diagnosed 15 with a condition and 25 without. So we now go through and combine this, of this 10 here, right, as well as then the 7 that were negative. If we look at these each individually, right, 8 of them now were appropriately classified. 7 of them were not appropriately classified of these individuals that had that condition. Whereas now here we have 2 individuals that were told they had the condition by this fictitious test but did not, and then 23 false negatives or true negatives. And so you can see then how we create this situation where all 40 individuals have been accounted for, all right, and we just classify them based on whether or not there was agreement or disagreement between the tests. This creates basically an idea of the overall accuracy of the test. And so we can go through and just calculate the number of true results over the number of total patients to create a percent accuracy. Basically, overall, in both assessing individuals with the condition and individuals without the conditions, how accurate is this exam? All right. The problem with accuracy is we only get to the point that of the overall effectiveness of the clinical diagnostic test that we're looking at. But in reality, we have a patient that has a positive or negative finding from this test. So we're really most interested in how accurate this clinical test is for individuals with that same same test finding. So by combining both positive and negatives into percent accuracy, we eliminate some of the ability of us to truly comprehend the ability of this individual test to both rule in and rule out the condition. And we're really only interested in one of those at a time because our patient either has a positive test finding or a negative test finding. So what we don't want to do is rely on percent accuracy where we're looking at the overall score. And what we find if we dug a little bit deeper in that is we see that almost all of the accuracy comes from finding individuals with positive score or positive tests, but ours has a negative test. And so you can see this in one of the tests that's fairly common is that Phelan's test, right? Where you go like this and you hold it here for 3 minutes. Almost everybody that has carpal tunnel syndrome will have a positive test with that. But there are a whole lot of false positives as well. So in reality, the Phelan's test is only really good at ruling out people with carpal tunnel test. If you're able to hold your hands like this for 3 minutes and not get any symptoms, you can be pretty sure that you do not have carpal tunnel syndrome. However, just because you hold your hands in that position for 3 minutes and do get some numbness and tingling in your hand does not necessarily mean that you have carpal tunnel. So we need to get into that a little bit more in depth and start to use some more mathematical equations to evaluate these findings for true clinical usefulness. And that's where sensitivity and specificity start to begin. So sensitivity now is the capability of the diagnostic test to correctly classify individuals with the condition. Basically the idea of true positives. So it's the probability of somebody with that condition of having a positive test. And so basically what we're looking at as far as sensitivity is the number of true positives over the number of people that have the overall condition. And so if you look at this true positives plus false negatives, this is the number of individuals that were identified by the reference standard as being positive. So we're looking at the probability of this positive test with those in the condition, right? And so you can now look at if we classify these as the box A over blocks A plus C. And so anytime we are doing any of these mathematical equations, remember that we end up multiplying these by 100 to get a percentage. Otherwise, we're just getting the decimal rating. And so you can see in this sensitivity example from what we've been talking about previously, we have the number of individuals that were identified correctly as far as the true positives in box A. And then we had 15 people, which is A and C, that were identified as the by the arthroscopic examination, multiply that by 100, and that gives us our sensitivity. The specificity then is the ability to classify individuals who do not have the condition. And so we look at this in the exact same way as previously, but now we're looking at the true negatives. Right? And so we can get in this idea of sensitivity and specificity now looking at the probability of accurately assessing individuals with or without the condition. How confident we are that the test will get people with the condition or without the condition in the appropriate classification. But even then, we're still in this idea of percent accuracy. We're going to continue to move beyond that to look at more and more accuracy measures. And so ideally we would like to have high sensitivity and specificity, but those measures are very much related to this idea of prevalence. And how prevalence, as we'll see, is going to be the number of conditions within a population at a given period of time. So the idea is how many individuals actually have this condition. And that's going to be beneficial in a couple of different ways. One, it greatly affects the ability to understand sensitivity and specificity measures, but will also serve as our foundation for the overall view of possible diagnoses. And so as we look through with these aspects, we can see that there are prevalence studies that occur which try to examine the number of individuals in larger populations that have the condition at any point in time. There's also in these prevalence data aspects, when you look at some of these sensitivity and specificity measures, we get in this idea of the population is individuals that sustained a similar mechanism of injury. And so we'll see that this ends up giving us and helping assist us with what we will call our pretest probability. But from there, once we have the prevalence established and the sensitivity and specificity, what we're really trying to do now is start to get from this contingency table and understanding the test's ability to classify people to now help us make decisions. And so we're going to look at what we call these predictive values. And now at this point, we're trying to judge from the sensitivity and specificity, not only the ability of this tests now to accurately quantify the number of people within these conditions, but how predictive is it as far as moving the needle to create a new situation where we can increase or decrease our confidence within a specific category. So the first one is the positive predictive value. And this is an estimate of the diagnostics test's ability to correctly determine the proportion of patients with the disease from all the patients with positive tests. So now, compared to sensitivity and specificity, where we were comparing and looking at the specific ability of the test relative to the reference standard, we're now going to look at the ability of the test to compare and differentiate with itself. And so this is a little bit more applicable to what we are in fact doing, because we only really have two different choices within our clinical test. And so we're going to look now, as opposed to comparing everybody with the condition, we're going to look at how predictive a positive test is versus how predictive a negative test would be. So the idea here is, opposed to comparing the true positives to everybody with the condition, we're comparing now the ability of this test to differentiate between positive and negative individuals. So we're comparing now box A with the sum of box A and B. This idea that yes, some tests may be able to identify, like that Phelan's test, everybody that has the conditions, which would indicate a very high sensitivity, but it has so many false positives that just because they're positive does not really give us a good predictive value. And so the idea here is we need to basically subtract the amount of false positives, because you could have a very high sensitivity by just saying everybody is positive and you will never miss anybody. But that's not the purpose of our clinical tests. In fact, in athletic training, one thing we pride ourselves in is we try to minimize the amount of unnecessary testing, right? Or the unnecessary number of referrals. And so the idea that if we have a test that indicates everybody needs advanced testing or advanced procedures, that's not going to be very helpful for us. Whereas we want to be able to differentiate that, and the positive predictive value tells us that information. So once we have a positive test, how much more sure are we that this individual has the condition compared to our prior estimate? And so we'll be able to use that separately. And the same thing occurs with the negative predictive value. We want to know that how much does the fact that our individual has a negative test move our level of belief that they do not have this condition. And so in order to understand that, we're looking at this negative predictive value, looking at the number of true negatives over the total number of negatives that the clinical test then indicated. And so you can see the example there and redo the math and this idea that in this case we have an 80% positive predictive value and a 76% negative predictive value. But from there, what we need to do is we need to start to interpret this information. And so now that we have this predictive value, this is where we can start to very much start to change our thinking as far as our diagnosis based off of the ability and the predictive ability of the test that we're looking. So these predictive values, positive predictive values, negative predictive values, sensitivity and specificity are often presented in these research that we've evaluated. If it's not, it's fairly easy for us to then calculate ourselves and start to use. And so the idea now is if we have a positive predictive value of 80%, that means that the estimated probability that the patient has the disease in question given a positive test is 80%. So the idea now is just based off this test, the fact that this test is positive gives us an 80% confidence that this individual has this condition. So now you can see where we're starting to quantify this, opposed to just saying, hey, I think you have an ACL tear. In this fictitious example, we could say, hey, we're 80% confident that you have an ACL tear. Now, what does that number really mean for us? Well, in reality, most of the time, the patient is not very interested in the actual percentage. But what we can start to do is start to use these and start to think about how we can go about then setting what we would describe as cutoff scores. And there are different aspects with cutoff scores that are discussed in your book chapter, and I don't want to get too crazy in cutoff scores, but this idea can then be, okay, if we're 80% convinced that somebody has a ACL tear, obviously we're going to send that individual for advanced testing. But now let's say we're 50% convinced that somebody has an ACL tear. Do we send them for advanced testing? Well, I don't know. Probably, because it's 50-50, right? If we're 25% confident, do we send them? Maybe not, right? But we can start to create this situation where we can start to create what is termed that cutoff score. Basically, at what percentage or what point are we confident that this individual has this or does not? But by creating these scores, as you'll see, we'll be able to continuously manipulate that data to get to our final percentage and thereby have confidence in our situation. And so how this works in real life is we're going to create what we call this pretest probability. And the pretest probability then is the probability of the target condition being present before we do anything. So just based off our clinical knowledge as well as our knowledge of the prevalence of the condition. And we can find that information in the research, and there's a lot of different aspects with their injury surveillance things, and we'll talk about epidemiology data next time that will help us in this prevalence. But we can know basically based on the individual, their mechanism of injury, the sport they play, about how probable it is that they've sustained this injury. Then from there we can use diagnostic testing and manipulate that based on its positive and negative predictive value to come out with a post-test probability. And this is the probability that they have the condition after the assessment. And so when we look at this, we're trying to create this situation where we can have a confident belief that our diagnosis is correct. And so when we go through and we do all of these, we start with that pretest probability, which is our normal evaluation process as far as history, our inspection, palpation, all that sort of stuff. We can create both from the prevalence and that a pretest probability, which would basically then be like, at the end of this, I'm 50% convinced that this individual has an ACL tear. And we can get that information from any sorts of different components. And we'll use that in conjunction with those positive likelihood ratios to then get into these situations. And so we go from positive predictive values to now these positive likelihood ratios. Just furthermore math as far as things go, where we're combining the sensitivity, specificity, right, and those predictive values in a specific way that we can now find the odds associated with these tests. And so tests with a high positive likelihood ratio will then link that into their ability to have somebody with the positive test result with somebody that has the condition as compared to somebody without. Negative likelihood ratio is the same, where we get now 1 minus the sensitivity over the specificity, or you can see there. And basically, the idea is if we have a very low ratio compared to a very high ratio for positive likelihood ratios, the lower the positive or the negative likelihood ratio is, the better it is at differentiating between those with and without the condition. And so we can see the math go here. And so now we can see a positive likelihood ratio of 6.6 and a negative likelihood ratio of 0.51. And so what this means is that because this individual has a positive test, they are about 6.5 times more likely to have the condition than a person without that test. And so you can see how we're starting to really use this to create a situation where from their pretest probability, if they then have a positive likelihood ratio of 6.6, that shows that we now have 6.5 times more likely that they have that condition. When we combine that with their pretest probability, we can then create a new mathematical equation associated with that, same with the negative likelihood ratio. We consider basically a positive likelihood ratio of greater than 1 and a negative likelihood ratio of less than 1, 1 being basically absolutely no good. And so we can classify these according to their strength. And we say that basically over 10 for a positive likelihood ratio or under 0.1 are very large and conclusive changes from pretest to post-test probability. And so the idea here is the higher the positive likelihood ratio or the lower the negative likelihood ratio, the more we can change our decision simply based off of that test alone. Whereas if we have low positive in the area of 1 to 2, or in the area of 0.5 to 1 in the negative likelihood ratio, the pretest probability shouldn't change at all because the test is not going to help us be able to differentiate those. And so in some question whether or not the test should even be performed then if it has a relatively low likelihood ratio. And so you can see this with different test options. When we have these different tests associated with different conditions, their positive likelihood ratio and their negative likelihood ratio should be used to differentiate which tests we perform as well as which test we then give most credence to in making our decisions. Right? And so when you look at all of these sorts of differences, and we'll talk about these specifically, right? Sensitivity and specificity versus predictive values versus likelihood ratios. Sensitivity and specificity are really only useful when either of them is very high. So if you have very high sensitivity or very high specificity, you will then be able to say that those with that condition definitely have a positive test where you've got most of them, and so that's really important. So like we talked about the Phelan's test having that high sensitivity, where we know that those individuals with that condition of carpal tunnel will have that test. You could see that be very important for like a concussion test, where we really need to make sure that we captured all of these individuals. And so in that case, a high sensitivity or high specificity would be useful. But predictive values now give a positive or test result with that. And what does that mean versus the probability of the disease? So what we're looking with these predictive values opposed to the sensitivity and specificity is the accuracy of the test itself, as far as how well it differentiates between a positive test and a negative test. Basically meaning now, if we have a positive test, how confident can we be in that compared to a negative test? And the big difference with this now is going to be whether or not the predictive values don't tell you whether or not you're comparing to the gold standard, but whether you're believing the results themselves. So sensitivity and specificity tell us how the test does compared to the gold standard, whereas the sensitivity and specificity tells us whether or not we should believe that test result. Predictive values then get into the higher levels. Basically, now how can we manipulate pre-test to post-test the probability of the target condition being present? And so when you look at these, in all reality, the ability to understand the differences isn't as important as the ability to understand the process of trying to use this to create a situation where we can then go ahead and create a accurate diagnosis. So unlike sensitivity and specificity, right, predictive values are dependent on the test and the population that you're testing. So when we get into this situation, we really have to be able to understand that their prior probability of having the condition is going to change depending on the testing, and it's going to change those predictive values. And we'll see what that means here momentarily. But first, as we continue to explore these differences, sensitivity, specificity versus predictive values, when we need to understand or consider the prevalence of the condition, we can use sensitivity and specificity data beforehand, whereas positive predictive value of a condition with a lower prevalence will be less than the predictive value of a condition with a higher prevalence. And so as we get this prevalence change and the population, we will then be able to understand better or be able to change our levels of understanding regarding the change in understanding of the condition. So the idea very much here is, as we get into these positive predictive values and negative predictive values, always remember that as prevalence increases or decreases, these predictive values are going to change themselves. All right? But when we get down to the brass tacks, so to speak, of this, if you get rid of all of that stuff that we've basically been talking about before and just focus on these likelihood ratios, this is where you're going to get to most clinical usefulness. So study sensitivity, specificity, positive predictive value, negative predictive value. Study how they are calculated, as well as what they're useful for, but understand that likelihood ratio is going to be our most clinically predictive, because this is going to be now our ability to change our minds. And so it's nice in that it basically combines a lot of these into what we can term a summative clinical index. Right? And so here we go into this likelihood ratio. We look at the probability of an individual with the condition having the positive test result versus the probability of an individual without the condition having the test result. So we can get in this positive and negative predictive values, continue to look at that. But when we get into this, we're now going to go back to our pretest probability, the chance of the patient having the condition without any testing. We're then going to use the result of the test and the test characteristics to then change our level of understanding. So what we end up doing here is we take our estimate of the pretest probability. This is based off our clinical knowledge as well as evidence regarding prevalence. So this idea that we can come up with a numerical value to basically guess what our overall assessment is. We can then continue down to this and try to create a situation where it means at what point are we going to then change our clinical decision making. And so we can work our way through this process where we create our pretest population. We then calculate the post-test odds using the information that we gathered from the positive or negative tests and calculating our post-test odds. And so our post-test odds are going to simply be the pretest odds multiplied by the likelihood ratio, either positive or negative, based on whether or not that test condition occurs. And so this is going to adjust for that overall prevalence. And so you can see the example here as far as pretest probability and prevalence, where we can go through based on individuals with this component. We can say the number of people in this population for the prevalence. These are the number of people that have the condition overall, right? A plus C over the total number of people. And that's basically the percentage of people that present with the specific inclusion criteria that was used in this study. Remember, the inclusion criteria is either going to be a specific group, right? It could just be like in the eating disorder studies, just athletes versus non-athletes, or oftentimes in these studies, it's going to be people that present with a certain set of symptoms. And so we can understand from that and create our pretest probability and our prevalence based off of if they have this inclusion criteria, this is the number of people that have the condition over the total number of people that were there. We can then multiply that based off of our post-test criteria and continue to create this situation where we can then get to our post-test odds. So if we go through and look at our prevalence and create our pretest odds over our and create that as a numerical value, we then can multiply that by our positive predictive value in the case they have a test, and that will then give us our new post-test probability. Right? And so our post-test probability in this case would end up being at right around that 80% confidence that we believe this individual has that. And you can calculate these examples and continue to look at this idea of how this works in real life. But basically, what you need to think of for diagnostic testing is pretest probability multiplied by the likelihood ratio equals your post-test probability. And this creates the situation where you can then be confident in how you can go through. And there are different ways that you can study this and look at that as well. And then this nomogram that we saw before basically does the math for you, where here's your pretest probability, here's the likelihood ratio, and then the post-test probability. You can see even if you start with really low, very low pretest probability, but a very high likelihood ratio, you can see how that would continue to increase your probability. And you can do this for each test over and over and over. And we'll see that when we look next time in clinical prediction rules. And so when we look at this, basically for this, you need to take some time, look at these different conditions, these different things, study them, know their formulas, know what they mean, but then get down to the brass tacks. And how we use this is we create a pretest probability from the prevalence of the condition, multiply that by the likelihood ratio, and that gives us our post-test probability.